Hello, citizens of Internet. I am Professor Ajit Virkud from Mumbai, India. This is the second installment of my comprehensive masterclass on non-alcoholic fatty liver disease, where I will delve into the intricacies of its diagnosis. Prior to starting this masterclass, I would like to address a point that was not adequately emphasized in part 1. This point being the genetic predisposition to liver disease. Numerous clinical studies involving family members have demonstrated that the first degree relatives are at a higher risk for non alcoholic fatty liver disease, NAFLD, suggesting a genetic predisposition to the condition. The majority of the studies suggest that the gene PNPLA3 is involved, with the I148M variant being strongly associated with increased susceptibility to NAFLD. Consequently, parental history is considered a risk factor for developing hepatic steatosis even in the metabolically healthy individuals. One more thing, many Western experts pronounce the acronym NAFLD as NAFLD. Because I find this pronunciation more appealing, I will use it in this section. Given the predominantly asymptomatic nature of the disease, laboratory investigations, imaging modalities, and invasive procedures are indispensable for establishing an accurate diagnosis of the condition. In most cases, fatty liver is inadvertently detected during an abdominal B mode ultrasound performed in conjunction with a pelvic ultrasonography done for a gynecological complaint in female patients. Male and female individuals who undergo routine yearly ultrasound examinations as a part of their health checkups are also found to have fatty liver. On ultrasound images, steatotic livers appear brighter than normal livers, while cirrhotic livers, that is, those with advanced fibrosis, appear lumpy and shrunken. In these ultrasound images labeled 1A and 1B, one can see mild increase in liver echogenicity compared with the kidney. Images 1C and 1D below show grade 3 diffuse fatty inflammation with a marked increase in the liver echogenicity relative to the kidney and no visualization of the intrahepatic vessel borders and diaphragm and posterior portion of the right lobe of the liver. However, by the time fatty liver is detected, it is quite late as the patient has already accumulated 25% or more fat in his or her liver. The accuracy of B mode ultrasound is reduced in patients with excessive abdominal gas, morbid obesity, and small amounts of fat infiltration. To enhance its sensitivity, a semi quantitative scoring system such as Hepatorenal Steatosis Index (HRI) has been employed. The optimal threshold for diagnosing NAFLD using the ultrasound liver kidney ratio is 1.24 with a sensitivity of 92%. Hepatic steatosis can be diagnosed on CT and MRI also. On CT scan, findings indicative of fatty liver are hypoattenuating region, that is 10 HU, which stands for Hounsfield units, less than spleen on non-contrast CT, or 20 to 25 HU Hounsfield units, less than spleen on portal venous phase contrast enhanced, or absolute hepatic attenuation less than 40 HU. It is important to remember that when comparing spleen to liver contrast, do not measure during arterial phase because in this phase, spleen is much more hyperdense. MRI findings suggestive of fatty liver are signal drop greater than 15% on opposed phase contrast compared to in phase contrast. T1 findings are hyperintense liver and T2 findings are mild hyperintense liver. These diagrams illustrate the radiological features of steatosis. On imaging modalities, Steatosis can manifest as diffuse, which is the most prevalent form, accounting for 25% of patients. It can also manifest in less common atypical forms such as geographic, that is, multiple wedge shaped appearances, focal, and multifocal appearances. Atypical forms can pose diagnostic challenges. One additional point to consider is that in some instances, the steatosis observed may be transient and resolve within a few days or weeks. This phenomenon is referred to as transient steatosis. The following conditions are associated with subacute or acute accumulation of hepatic lipids: prolonged fasting, which induces a ketogenic state, consuming one or multiple consecutive extremely fatty meals, and severe alcohol intoxication. Consequently, a novel technique called elastography has been introduced for quantitatively determining the extent of fibrosis, that is, intrahepatic steatosis, with greater accuracy. Utilizing this machine, equipped with vibration controlled transient elastography (VCTE), controlled attenuation parameter CAP in short, and liver stiffness measurement, that is LSM, data can be obtained simultaneously. Currently, CAP technology is available in two devices: the FibroScan system from company EcoSense from Paris, France, and the FibroTouch system from China. A CAP value of 331 decibels per meter serves as a pivotal indicator for ascertaining the severity of steatosis. When measuring CAP, two distinct probes, M and XL probes, are employed. No statistical difference exists in the diagnostic accuracy between these probes. The FibroScan system possesses the capability to accurately determine the degree of hepatic steatosis and facilitate dynamic monitoring of hepatic steatosis in clinical practice. FibroScan must be repeated every 2 to 3 years. However, it is important to note that FibroScan may not detect fibrosis until the liver is already significantly affected, typically exceeding 25%. Furthermore, the most significant limitation of FibroScan is the elevated BMI and age of the patient, particularly in individuals over 35, where false positive rates are quite high. Cost is another factor that restricts its widespread adoption. In response to these limitations, newer and more innovative ultrasound quantitative technologies have emerged to enhance diagnostic accuracy. These technologies include attenuation imaging (ATI), shear wave elastography (SWE), and acoustic radiation force impulses (ARFI). However, these technologies are still in the preclinical stage of development. Recently, several non-invasive combination models have been reported for the identification of liver fibrosis and non-alcoholic fatty liver disease. Non-invasive stiffness-based models such as magnetic resonance elastography (MRE) combined with FibroScan and AST, that is fast, and magnetic resonance imaging combined with AST levels, that is MRI AST, or MAST in short, and magnetic resonance elastography plus FIB4, that is MEFib, all provide a practical foundation for risk stratification in NAFLD. The last one, that is MEFib, stands out as a superior and more rapid method for detecting significant fibrosis and high-risk NASH. Blood-based non-invasive tests and elastography combination models are highly effective in ruling out disease with a negative predictive value (NVP) exceeding 85%. Conversely, the MEFib combination model demonstrates a high positive predictive value in PPV of over 90% in the identification of cirrhosis. However, it is important to note that these emerging ultrasound technologies are still in early stages of development and application. the limited number of high quality studies further emphasize the need for additional research and validation to ensure their reliability and efficacy. In the FibroScan 4, that is FIB4 combination model, four parameters are considered: age, liver enzymes such as ALT and AST, and platelet count. It is calculated by using the formula age multiplied by AST, and this result is divided by outcome of multiplication of platelets and ALT. A FIB score exceeding 1.3 is generally indicative of potential advanced liver fibrosis in patients with non-alcoholic fatty liver disease, suggesting a higher risk of non-alcoholic steatohepatitis NASH and necessitating further investigation with more definitive tests such as liver biopsy. Conversely, a score below 1.3 is typically considered low risk for significant fibrosis. However, it is important to note that FIB4 score can be influenced by age, particularly in individuals over 65 years. Its accuracy may be limited. This table shows comparison of failure rates, invalid result rates, and confounders of various fibrosis markers. Perhaps the most accurate test is 2D MR elastography, which is not confounded by patient's age and BMI. It has 0% invalid result rate. You can pause the video here if you want to know more details about the various markers. What is the role of liver enzymes as a marker for diagnosis of liver fibrosis? It was initially thought that abnormal liver enzymes such as high ALT suggest that the patient has higher probability of having NASH, but this is not true. Patients with normal liver enzymes, that is less than 30 international units per liter in females, may still have advanced fibrosis. Normally, AST to ALT ratio is less than 1. A ratio greater than 0.8 suggests NAFLD, that is advanced fibrosis, and that greater than 1.5 suggests alcohol-related liver disease. In any patient, persistently elevated ALT is associated with cirrhosis and hepatocellular carcinoma. Thus, in any patient diagnosed with NAFLD, liver enzymes must be checked regularly, and if found persistently high, such patients must be managed more proactively. They may be included in clinical trials of newer experimental medical agents. Muscle fat analysis plays a crucial role in diagnosing non-alcoholic fatty liver disease, NAFLD. Increased muscle fat content or myosteatosis is strongly associated with the presence and severity of NAFLD, particularly in more advanced stage known as NASH. This suggests that muscle fat infiltration could serve as a marker and potential contributor to NAFLD development and progression. Therefore, determining fat content in muscles, specifically sarcopenia, through muscle fat analysis is recommended for these patients. Treatment options can be tailored based on the extent of fibrosis and muscle fat analysis results. Are there any other biochemical abnormalities associated with non-alcoholic fatty liver disease? Yes. One such abnormality is elevated ferritin and transferrin saturation. Elevated ferritin levels greater than 1.5 micrograms per liter may be associated with increased fibrosis, while elevated transferrin saturation increases the risk of hepatocellular carcinoma. It is possible that these individuals have higher iron absorption rates, although this remains to be further investigated. If the diagnosis is still uncertain, a liver biopsy may be necessary to quantify iron and fibrosis stages. Thus, if serum transferrin and ferritin levels are elevated, hemochromatosis must be ruled out in these patients through HFE testing. It is important to note that both conditions can coexist. Other biochemical abnormalities associated with non-alcoholic steatohepatitis NASH include the presence of autoantibodies. Patients with NASH may have mildly elevated anti-nuclear antibodies ANA and smooth muscle antibodies SMA. A NASH Clinical Research Network (CRN) study demonstrated that anti-nuclear antibodies ANA exceeding 1 in 160 and smooth muscle antibodies SMA exceeding 1 in 40 were present in 21% of patients without autoimmune hepatitis as determined by liver histology. If IgG levels are elevated or aminotransferases levels are greater than 5 units per liter, it is suspected that autoimmune hepatitis may be the underlying cause. In such cases, a biopsy is necessary to rule out NASH. A liver biopsy is considered gold standard for diagnosing non-alcoholic fatty liver disease, NAFLD, particularly when trying to determine the presence of non-alcoholic steatohepatitis NASH and the severity of liver fibrosis, as it provides a tissue sample for detailed analysis under a microscope. However, due to its invasive nature, it is not always necessary and is usually performed in cases where other tests are inconclusive or when there is a high suspicion of advanced liver disease. Please note, it's the only test that can confirm NASH and show the severity of the disease. These three slides show histological features of steatosis and non-alcoholic steatohepatitis NASH. Slide A, stained with chromotrope aniline blue stain at 200x magnification, shows macrovesicular steatosis. The hepatocytes are distended by large fat droplets. Slide B, stained with H&E stain at 200x magnification, shows NASH characterized by ballooned hepatocytes with lightly stained cytoplasm, some of them containing indistinct cytoplasmic inclusions resembling Mallory-Dank bodies, MDBs, indicated by arrows. These bodies are visualized as eosinophilic irregular cytoplasmic inclusions, often appearing as ropey or string-like structures on histological examination. Slide C represents features of NASH with ballooned hepatocytes, some of them containing MDBs, shown by arrows. Most hepatocytes are surrounded by pericellular fibrosis, seen as blue rims around hepatocytes. In set D at 200x magnification is immunohistochemistry picture obtained using antibodies to sequestosome 1/p62 containing MDBs that are colored red. Mechanism of these bodies is thought to be a result of cellular stress and impaired protein degradation pathways where damaged cytokeratins accumulate and aggregate within the hepatocyte cytoplasm. Before initiating treatment discussions, it is crucial to assess the extent of liver fibrosis. Liver fibrosis is categorized into distinct stages based on the proportion of liver tissue replaced by fibrous tissue. These stages range from F0 indicating no fibrosis to F4 characterized by extensive fibrosis. Stages F1 to F3 are considered reversible as further treatment can prevent progression. However, once stage 4 is reached, the disease becomes irreversible and manifests clinically as cirrhosis. Therefore, prompt diagnosis is paramount to prevent further progression and administer timely treatment, which is now available. The bar diagram shown here represents color-coded stages of liver fibrosis. Green bars denote F0 and F1 stages, while orange bars represent F2 to F3 stages, which are all reversible. Brown bars indicate F3-4 stages, which are likely or partially reversible. Finally, black bars represent F4 plus stage, which is irreversible. This graph presents the results of a meta-analysis involving 1,495 patients with non-alcoholic fatty liver disease. The patients had an average follow-up period of 17.45 years. The analysis revealed that patients with fibrosis exhibited a significantly elevated risk of all-cause mortality compared to those without fibrosis. The y-axis represents liver-related mortality. It is evident that the liver-related mortality rates increase exponentially from stage 2 fibrosis onwards. Consequently, stage 2 or higher patients require referral to a hematologist for appropriate treatment. The reference for this study is given below. This is a ready reference chart denoting accuracy, validity, and prognostic ability of many different biomarkers used for diagnosing different liver diseases like hepatitis B, hepatitis C, and NAFLD. Of these, APRI and FibroSure are used most commonly. Please note, these tests are not perfect. Having discussed so many different tests for diagnosing NAFLD and NASH, let me now summarize the criteria for diagnosing these liver diseases. From clinicians' point of view, the criteria for diagnosis of NAFLD are: 1. Hepatic steatosis on imaging or histology. 2. No significant alcohol consumption. What is significant alcohol consumption is shown in asterisks below. 3. No competing etiologies of hepatic steatosis. And 4. No coexisting causes of chronic liver disease, which is a changing paradigm. Criteria for NASH diagnosis from clinicians' perspective are: histology is the cornerstone for NASH diagnosis. Currently, there are no FDA approved biomarkers for diagnosis of NASH. Novel combinations of laboratory and imaging tests are inconclusive in diagnosing NASH. Whether laboratory tests can be used for diagnosis is questionable. Those with normal liver enzyme, that is less than 30 international units per liter in females or less than 40 international units per liter in males, may still have advanced fibrosis. Numerous research efforts are underway to identify non-invasive diagnostic methods for NASH. All in all, liver histology remains the only gold standard test for NASH diagnosis. This brings me to the end of part 2 of my masterclass on non-alcoholic fatty liver disease and NASH. Please watch part 3, which is about prevention and treatment of the disease. If you want to know more about this topic or any other topic in obstetrics and gynecology, please refer to my books Modern Gynecology, Modern Obstetrics, and Practical Obstetrics and Gynecology, and other books. For purchase inquiries, contact me on this WhatsApp number. I have also published 2 question answer books which are particularly useful for exam going students. These are Clinical Cases in Obstetrics, 1000 plus questions and answers, and Clinical Cases in Gynecology, 1000 plus questions and answers. You can also follow me on other social media platforms like Facebook or Meta, Blogspot, and Instagram. The links are given here. If you enjoyed this video, hit the like button, share it with your friends, and also subscribe to my channel for more videos like this. Thank you for watching.